Okay, welcome everyone. Today we have the seminar from Dr. Neri from Fresenius Medical Care. Dr. Neri earned his medical doctor degree and also a PhD degree in occupational and environmental medicine at the School of Medicine at the University of Milan. Then he joined the St. Louis University Center for Outcomes Research as an epidemiologist and management and policy in the same institution until 2013. Then in January 2010, he also joined the Department of Clinical Science and Community Health at the University of Milan, his hometown. His research interests spanned across multiple therapeutic areas. He collaborated with academic and commercial partners in developing new research, devising methods for answering investigative questions, and solving research design problems. He authored over 90 original papers in international peer-reviewed scientific journals in the field of outcomes research and epidemiology. He joined Fresenius as a data scientist in 2016, and he now leads the data science division in the clinical advanced analytics team for the Global Medical Office for the EMEA, LATAM, HC-AIxIA regions. The data science team develops AI tools assisting healthcare professionals undertaking complex decisions in their day-to-day work activity. So having said that, I really thank very much Dr. Neri for accepting our invitation, and I leave the stage to him that will give a talk with title Applications of Artificial Intelligence in Medicine, Challenges and a Story of Success. Thank you very much.
Thank you, Fabio. And the presentation will be, as said, divided into segments. The first one is a general introduction on why and how we develop our models, and the second section will be an example on how we developed and then implemented in our clinics one of these tools. So first, I would like to give you a little context on what Fresenius Medical Care is, so my employer. Fresenius Medical Care is a company that specializes in delivering care for kidney patients, kidney failure patients, and also it is a manufacturer of dialysis machines and dialysis equipment. So both on the manufacturing side and also in the care delivery side. Is a big company with over 100,000 employees all over the world. And with a very global coverage with 42 production sites worldwide. We provide both for in-center dialysis, home dialysis, and home dialysis, including peritoneal dialysis. So essentially we provide, except for kidney transplant, all the available options in nephrology. But we face problems that are common, and this is the motivation why we started, let's say, developing algorithms and tools that for decision support. We face the same problems that any other company in the healthcare sector is facing, including not only companies, but including governments. So here you see a graph showing the trend in healthcare spending worldwide. Of course, the highest spending country is the United States, and the trend increases, and also the speed of increase is higher in the United States. But the healthcare costs are increasing everywhere in all the countries, both in the developed countries and in countries that are, let's say, developing. This has not come with an increase in the cost of drugs. So cost of drugs, even though pharma companies, let's say, produce new technology continuously, the cost of drug is not driving the increase in cost in healthcare. And this increase in cost is coupled with a shortage of nurses. This is, let's say, a map that, let's say, draws from a study representing the scarcity of nurses in OECD countries Actually, I'm traveling throughout Asia, let's say, and this problem is present even in developing countries, let's say India, China, and also in developed countries like Korea that are outside the OECD. So it's really a global problem. The shortage of nurses and also the shortage of doctors, which is very severe, of course, in Europe. And when you have a shortage of doctors and nurses and also increasing cost, well, you have then as a result a mismatch between demand and supply. So if you look at this graph, there is a growing demand for imaging studies, diagnostic imaging studies, but then you have not a comparing increase in the number of consultants that can read those images. And this has, of course, consequences in terms not only on, let's say, the stress and burden of the doctors, but also potential medical errors and the long waiting list, a problem that is common to all countries. So when you look at the productivity of the healthcare sector, one important thing is that the productivity of the healthcare sector is not increasing as fast as the whole economy. You see, is very small, the increase in productivity in the healthcare sector, and that is one of the problem. Let's say one of the reasons why we have this mismatch between supply and demand. Of course, the number of doctors and nurses is not increasing, the demand increases, and then you need to produce more by unit of time compared to the past. And this is not occurring. So, and this provides a huge stress on any healthcare system in the world. The reason of this is quite simple. It is called epidemiologic transition. So all countries, including developing countries, are facing a transition from, let's say, an acute disease, let's say, epidemiology to a chronic disease epidemiology. And our populations are growing older and older and older. So we are reaching an equilibrium with a very low crude birth rate and a very low crude death rate. And that equilibrium brings higher average ages. And this is the big driver of cost. So when you look at the graph on the right, you see that the cost per patient depends, let's say, depends, or the overall cost depends on the number of comorbidities. And when you get older, you have a high number of comorbidities. For example, in normal dialysis patients have on average 5-6 comorbidities, and they take 11 pills a day. So they're very complex patients, they're old, and they cost a lot to the healthcare system. Most of this increasing cost is due to increased complexity of care. So we need to provide complex care with a lot of demands, managing a lot of problems at once. And in that context, of course, AI can provide a huge help. How? Well, for example, we can use AI to improve and standardize care and to reduce the time that we need to provide a diagnosis, for example. So in this example, an artificial intelligence assistant improves reporting efficiency of thoracic aortic aneurysm by reducing the reporting time by 60%, as you see in the graph on the right, and improve the inter-rater agreement by 40%. It is very important also not only the increase in efficiency, but the increase in consistency, because when you have an increased consistency, then not only you provide more equitative care, so everybody access a good quality care rather than, well, you resort on luck to find the right doctor, but it provides a way to streamline clinical processes with less chaos. In an orderly way, you can create workflows that are ordered and more efficient. And also AI can help us give priorities. When you have a patient with many risk factors, with many disease, you need to take strategic decision. It's very difficult to treat all of them at the same time with the same focus. And it's very common to see patients hopping from a specialist to another because there are several problems, several diseases, and they don't have a coordination of care. So with AI, you can profile patients, you can have a digital representation of the patient, and then you can provide personalized services that would target, let's say, the most important, let's say, aspects, the highest risk of the patient, and disregard and invest less in problems that are less important or provide less risk for the patient. Of course, there is a huge interest, a huge hype, or a huge interest, I would say, not hype, in AI and digital transformation, because everybody understands that the healthcare system will not make it without a profound change in the way healthcare is delivered, including digitalization. And of course, if you look papers, we have several that address this issue. I don't want to go through all of these because let's say, I just want to mention that is a very hot topic in the scientific literature. However, let's say, when you look at the real implementation of AI in clinical practice, well, the situation or the outlook is not that good looking. So for example, here you can see a study showing the rise, or let's say the trend in studies related to AI medicine, divided by, let's say, different designs. So when you look at whole publications, you see a very sharp increase in the number of publications on the topic. But when you look at clinical trials, that are the signal that companies are investing, there is a flat curve. There is not an increase, even in recent years. So, and also, if you look at the number of medical devices that are certified for use in medicine, you see that there is not a huge number, despite the very, very large amount of publications that every year we publish to show our work and to disseminate our work. So why that? What are the challenges that we face when we want to implement a solution, an AI solution in reality? Of course, there are general, let's say, challenges that you for sure have encountered, or let's say have read about. Ethics, accountability around efficacy and safety and trustability, increasingly complex regulatory pathways and cost to market. We will see some of these. Infrastructure readiness of healthcare facilities, information technology system. This is a huge problem. Lack of clinical integration of AI solution is a main topic in medical education. So doctors are not trained, nurses are not trained to understand what their AI tool provide to them. So they're trained to use a stethoscope, but they're not trained to use an AI tool, a decision support tool. They are not trained to understand it. How we can make sure that humans and AI, or humans and this technology work, is a topic of ergonomics, but also a cultural problem. So starting from the first point, so the first issue that we face is, of course, that when we try to propose our solution, there are concerns on the users, the doctors and the nurses, and also concerns about, let's say, our leaders, that we would be seen, or that we would, let's say, inject inequalities in the system, let's say inequalities in the equation, in the inequalities in the care that we deliver to the patients, because of algorithmic decisions that they do not control, they do not understand fully. And also because, of course, you know that most of these applications derive from real world data, and the real world data may, let's say, propagate biases in society that already exist. And when it comes to trust, well, there are, let's say, several aspects of AI that, of course, raise skepticism. Doctors, patients, regulators are skeptical about black boxes. So I want to read, let's say, verbatim, a quotation from a study published, from a review published on The Lancet Digital Health. Why we cannot trust artificial intelligence in medicine. Applying trust to AI is a category error, mistakenly assuming that AI belongs to a category of things that can be trusted. Patients place their health in physicians' voluntary responsibility and discretion and believe in physician benevolent motives. AI does not have voluntary agency and cannot be said to have motives or character. So I think that this quotation explains the confusion that there is, let's say, in the public around AI. We don't ask that kind of trust to AI. AI solves, except for generative AI, but I don't want to take, let's say, to go in that path. But let's say the more traditional, let's say, tools that we develop, they try to solve a specific, very well-defined task, cognitive task. So we don't need to give out our trust in that sense to an AI model. Still, of course, our models, the more complex they are, the less explainable they are. So if we build a model to explain the model, then we don't catch the complexity of the model and we will never give a real explanation. There is also another point. So even if we present the sharp values of our models, well, these are correlational. So it's not really an explanation. It's just showing why the model says things, maybe, let's say, with the simplification. But the most important point that I want to make is that why we are skeptical about black boxes, because for a long history of medicine, we have been using black boxes all the time. We are still using black boxes all the time. We assume drugs continuously, and most of the time, we don't know the exact detailed mechanism that explain the specific syndrome, the specific symptoms, the specific effect that the drug has on each single patient. When you look at aspirin, for centuries, aspirin has been used without knowing why it worked. Now we know that let's say it's an agonist or an antagonist of certain, let's say, receptors in the cells. But to each single patient, we don't know where these receptors are. We don't know exactly, let's say, how sensitive are to the drug. So each of us is slightly different in relation to the response to each drug. So knowing why we have a secondary symptom or an adverse event given, or a smaller, let's say, effect on any single drug is a mystery. It's really the interaction between the drug and us is really a black box, but still we trust. We take in our body drugs every day. So why we do that? Well, because medicine has developed a path, a very regulated path to trustfulness. So which is the drug development process, which is staged, and it includes several, let's say, assessment and test of the efficacy and safety of the drug so that we can characterize it. We know exactly the properties of the drug in general as an average for the population, and we accept the risk. And so at Fresenius, but in general, I think that a sensible, let's say, development process for AI should mimic in some way what we do for drugs. So we start with trying to understand, let's say, what are the demands, the medical needs. So for doing that, we have methodologies to, let's say, assess, let's say, the medical and procedural pain points that our doctors and nurses face by interviewing them, by doing sort of etiological studies. So we go to the clinic, we stay there for days and see, let's say we look, take notes about what procedures they do. And we study problem by problem which kind of behaviors, decisions they make on a daily basis. And based on that, we try to devise ideas, and we leverage on the data that we collect in clinical practice to develop our model. This is actually a very small part of the job, because the real, let's say, complexity start after the model is developed. A very important phase is digital development. So we the aspect that are more complex are how we integrate the solution into our clinical workflow, how we integrate the solution in our IT system, how we develop a user interface. And here we, of course, use several techniques of ergonomics to develop the user interface. But most importantly, cybersecurity, privacy and confidentiality, and of course, the regulatory pathway. In Europe, we have one of the most complex regulatory pathways for AI that we have in the world. At each release of our AI models, we need to fill in 280 documents. These are reviewed and signed normally by 2 or 3 people, so you can understand the complexity. Now with the AI Act, I expect this number will increase even more, and that creates a big, let's say, burden on who wants to put in the market, or wants to use this kind of software. So the MDR regulation is so broad that even simple medical calculators like the EGFR calculator, which is an equation with few variables, is considered a medical device. And then once you have done that, well, you have the phase of market access. So you need to do clinical studies. You need to understand whether the model really works in clinical practice. And then we have a very similar scheme to what we have with drugs. So we start with very small pilots in clinics. We collect data on clinical safety first. Then we expand the cohort until we reach, let's say, a sufficient number of patients to make claims about efficacy and safety. And then, of course, we have the obligation to do post-marketing surveillance and post-marketing studies, meaning that we need to follow up on patients that used our solution to understand whether they have, let's say, symptoms. Of course, there is a process of tracing any potential adverse events, like for drugs, and which is regulated. Then we have the obligation to follow. So one aspect that I want to touch very briefly after this is that, let's say, the collaboration and let's say the development of user interfaces for AI in medicine is a particularly important topic, because since at the end the clinical outcome depends on how the doctor use them, well, there is this new field, and I think that you know some of the people that published this paper at University of Milano Bicocca, say the development of, let's say, interfaces that enhance the collaboration between the user and the AI system are very important to improve, let's say, the clinical outcomes, but also reduce the untrustfulness, let's say, or to improve the trustfulness of the model. So in this study, for example, they have evaluated how doctors interact with an image, a software understanding, or let's say providing suggestion on diagnosis for bowel cancer. And they have observed that doctors are able to use the information that this tool provides in an efficient way, and improve at the end the outcome that they would achieve without have achieved without the use of AI. But let's say another topic that is quite important is how ready are our IT systems in the hospitals. So this is a huge problem that we have in implementing our tools. Essentially, it is easy to distribute our tools when in our clinics because we have our own health information system. Much more difficult is to export, or let's say to sell or to make available our tools to clinics that do not use our health information system, because most of the time the health information systems are not interoperable. For dialysis, let's say standard language, standard, let's say, nomenclature are not useful, like FHIR is not sufficiently detailed for dialysis. So each provider develops their own ontology. So it's very difficult to make sure that the health information systems can let's say communicate with the tools. Is a very hard job. But not only that, so the readiness of the IT departments in the hospital is always a little bit behind. So it's very difficult to cooperate with them, and we have very big practical problems in cooperating and creating a system that is as efficient. Also, there is some resistance to go to the to use the cloud, any cloud solution. Everybody wants on-premise solution that of course has much less capabilities. And also we have problems about, as we said, let's say on the readiness of doctors and nurses in using these tools. We have run a survey in our clinics where they have some, let's say, exposure to AI, and however, the vast majority of the interviewed people said that they haven't got the opportunity to work with AI at all. And when you look in the past, and when you look at the offering of medical universities, well, it's very poor. So I think that it's very important that the medical community is instructed and educated on AI. I would like, let's say, to see more classes on AI in during medical education, even before specialty, because I think that this is, let's say, the stethoscope of the future. So we need to provide these students the opportunity to be exposed to that knowledge way before they enter a clinic. So as a second part, I want you to present, let's say, to show you an example of how we implemented and how we developed and implemented a tool in our clinical network, just to provide you an example on how we try to solve these problems. And so I will talk to you about the anemia control model. So the story begins with, let's say, our health information system that is called Euclid. As said, we provide care to a very large population of dialysis patients throughout the world. You see the map in blue of countries where Euclid and where our clinics are distributed and where Euclid is used. So for example, you don't see United States, even though we have a big presence there, because they don't use Euclid. That is the database that we use to develop our tool. It is used by 20,000 physicians and nurses in different languages, 20 languages, 100,000 active patients, and 126 millions of dialysis sessions stored in the database. This is the structure of the database. So not really the structure, but the variables, or let's say the functions that the database has. So we use it for patient management empowerment, so patient scheduling, CKD management, in-center HD, and many other tools, interactions with other systems. So we connect with labs, we connect with machines, so we have the data from the machines as well. We connect with the local registry, invoicing system and so forth. And of course, we use it for clinic management, let's say in terms of, let's say, managing the personnel and managing the water system and other stuff. And of course, then we use it to monitor and to monitor outcomes and to do research using, let's say, secondary use of data. So what is the anemia control model? Anemia is a big problem in dialysis. All patients in dialysis have anemia, and 90% of them use erythropoietin stimulating agents to treat it. Why they have anemia? Because the kidney has a pivotal role in regulating hematopoiesis in the bone marrow. When the kidneys do not work, then also erythropoiesis does not work. And the response of the patient to erythropoietin stimulating agents is strongly dependent on several time-varying factors. They change continuously: chronic inflammation, other causes of hyporesistance, malnutrition, iron deficiency, dialysis modalities, hospitalization, acute inflammation, bleeding, infection. So you can imagine that this complexity is very difficult to manage for a doctor. There are a lot of inputs that should be processed, and they have very little time to decide because they have a busy clinic. For this reason, target achievement is quite low. I want you to focus on this graph a second, because that will relate to the results of ACM later on. On average, this is a graph representing target achievement for hemoglobin in the UK in 2015. The report is 2016. If you take the picture last year, is exactly the same. It doesn't change. This is a long-lasting problem, very difficult, challenging problem to solve from a clinical perspective. The average target achievement rate is 60%, with quite a bit of variability. But look at the number of centers with target achievement above 70%, only 2. Okay, this hasn't changed. When you look at other registry, you see the same thing. Another point is that let's say HP of the patients fluctuates, because the reasons why they respond or not to ESA fluctuate, to the erythropoietin stimulating agent fluctuates as well. And this is linked to hard outcomes. So it's important to address it. So essentially, optimal anemia management means that you need to assess the causes for uncontrolled anemia and use the lowest possible iron and ESA dose, because they are also toxic. So you cannot give the patient. They cost a lot and they are also toxic. So there is a warning of FDA that ESA is associated with death. So they suggest to use the least dose possible. So this is why we developed already 10 years ago, actually, an artificial neural network, not, let's say, the last technology available, but at the time was quite innovative. So we used an artificial neural network to estimate the dose-response relationship between erythropoietin stimulating agent, iron, and the change in hemoglobin between 2 consecutive months. Then we use that model to simulate the dose-response relationship for each patient, and we use a reward function to select the optimal dosage. After development, we went through several clinical testing. This is the, let's say, and to do the testing, we first needed to integrate the software in Euclid. Euclid is our database, I remember. I remind. So essentially, we have a service that is connected to the clinical information system that exchanges data to the health information system, and then is presented to the doctor. And then the doctor can choose through the user interface whether to accept or not the recommendation. And if the doctor accepts it, then this prescription is communicated back to the health information system, and it becomes a prescription, a medical order. So after this implementation, then we tested in clinics, and we did a prospective clinical study to assess the efficacy and safety of ACM in clinical practice. So we compared patients treated without ACM and patients treated after the use of ACM. And you see that after the implementation of ACM, the target achievement increased by around 30% from 64, which is very similar, to this average that we have seen in the registry before, and 84%, a huge increase. And when the patients were treated consistently with ACM, so 2/3 of the treatment were used according to ACM suggestions, then this improvement was even bigger. On the other side, when you look at HC-AIxIA consumption, you see a reduction in the consumption of erythropoietin-stimulating agent that is quite remarkable. So meaning that we not only improve target achievement in hemoglobin, but also we reduce the usage of the drug by using this software. And then the next step is how generalizable is. So we developed it in Europe using European data. Can we generalize over different ethnicities and different races? So this is an important question that we need to address before, let's say, exporting or using the software, let's say, in other regions, in other geographies, and even in other clinical settings. So we are using this Apollo database to test these hypotheses, and we, in general, devised a process to assess generalizability of the tool in different settings, which we call feasibility analysis, essentially. And so we test locally using sampling of the population, and then we test the accuracy of a model, and we generate then a risk matrix assessing the risk of projecting the risk of adverse events based on the performance of the model. So this is the pattern essentially that we use when we want to deploy ACM in a new clinic that is in a different, let's say, geography, or where there is some concern about the generalizability of the model so far. So if the ACM is to be deployed in a new clinic, then we run this feasibility analysis. That means that we first do a qualitative assessment of clinical practice. So we need, for example, a monthly assessment of hemoglobin. This is pretty standard in many countries, not in all countries, of course, or in the clinical practice. And then, of course, if we have suspicions, then we do a formal risk assessment. So we extract local data, we run the model, we run the model, the artificial neural network on that data, and we observe the error of the model, and then we create a risk matrix that we compare with the one that is published and registered for the medical device registration of ACM. And then, of course, then we train the doctors and run the pilot, a first pilot, before a large implementation. And in the pilot, we assess the outcome every 3 months for more or less 6 months. So now the model has been used since 9-10 years in many clinics in our network, and this is why we have a huge amount of data that we can use to corroborate the initial findings that we had when we launched it. So we did a study using a propensity score matched design to compare patients treated with ACM against patients that were not treated with ACM, using 3 different, let's say, reference categories, where we sampled patients from centers that have a target achievement below 70%, patients from centers that have target achievement of 70 to 80%, and patients sampled from centers that have a target achievement about 80%. And these are the results. So essentially, we confirmed exactly the same number of patients on target that we have seen in our first clinical trial, in our observational study. And we compare it with the 3 different reference group, where, of course, you see that when the clinic per se doesn't, let's say, is the lowest, let's say, in our network, target achievement is around 70%, which is already the standard of care, then there is a big improvement in outcomes with increased target achievement rate, reduced inappropriate HC-AIxIA use, and reduced anemia. But of course, when you compare with excellent clinics, then ACM does not provide a big advantage, except for reduction in inappropriate HC-AIxIA use. And this is reflected in the usage of the drug. So this is a quantile regression for the same study, where we compare. So the bold line is ACM, and the other lines, the dotted lines, are the comparison groups. You see here that for ACM, ACM suggests much more likely no dosage for HC-AIxIA in specific months, meaning that the wastage is let's say, in the reference group, in the doctor-led, let's say, practice, is due to the fact that the doctor almost never gives zero. So they're afraid of giving zero. They give zero dose less frequently. They give some drug, even if it's not necessary. So ACM is able to reduce that wastage. So in conclusion, well, ACM is now rolled out in 18 countries in the 3 continents. We are expanding, and in 2023 produced 90,000 suggestions for HC-AIxIA and iron to our patients. Take-home messages, and then I will conclude. So essentially, the cost of healthcare is rising. AI is, let's say, a candidate for a huge, important transformation of healthcare toward more automation, and so improving access to healthcare for more patients. So a big raise in productivity. However, we are facing a lot of challenges in translating the good, let's say, wonderful achievement that we have in research into clinical practice. There is a mismatch between the severity of the regulation and the reimbursement that we get. There is no reimbursement for medical devices. There is no reimbursement for AI, even if we have proven efficacy. We can prove efficacy and safety. There is no reimbursement compared to drugs, where, of course, the reimbursement is. And so if you have a regulation that is very severe and no reimbursement, then there is little investment. I'm sorry, but then this is a harsh reality that we need to face. There are many other challenges in clinical practice that we already have mentioned, but there are also a lot of opportunities. And for example, ACM is an example of how challenges can be overcome, especially when it comes to large and managed care organizations that can leverage on economy of scale. So with that, I thank you very much for your attention, and I'm open to take questions.